Hey, you're still here. Okay, let's proceed to the part 4. Let's start. Novel techniques. 3 novel techniques have been investigated in the performance of an appendectomy. We have single incision appendectomy, natural orifice transluminal endoscopic surgery or NOTES, and robotic appendectomy. Single incision appendectomy has not been shown to improve outcomes, including cosmetic outcomes. Prospective randomized studies has been suggested to have a higher incisional hernia rate. NOTES surgery has been shown to have better cosmetic outcome and less post-operative pain in a meta-analysis of NOTES procedures, including appendectomies, although only 40 patients were included in the analysis. The risk of luminal contamination and closure of enteral or vaginal mucosa remain suboptimal. For this reason, there has not been widespread dissemination of this technique. Robotic appendectomy allows flexible motions of intraperitoneal instruments and is therefore superior in ergonomics for the surgeon. However, it is extremely expensive and requires larger ports based on most of the current platforms. Thus, this technique is not utilized widely. That's it for novel technique. Next is negative exploration. Upon performing a laparoscopy or laparotomy for suspected appendicitis, if one finds no evidence of appendicitis, thorough exploration of the peritoneum must be performed to rule out a contributing pathology. Normal appendix is often removed to reduce future diagnostic dilemma. Management of incidentally found common conditions is summarized in the table 30-3. We will see and read it later. Next is incidental appendectomy. The practice of prophylactic appendectomy has been considered during other operations to prevent the future risk of appendicitis. It is routinely performed in children undergoing chemotherapy, compromised host with an unclear physical exam, patients with Crohn's disease with a normal cecum, patients traveling to remote places with no urgent care, and in patients undergoing cytoreductive operations for ovarian malignancies. While there is no evidence clearly evaluating long-term outcomes of patients undergoing incidental appendectomy with an asymptomatic appendix, the risk of adhesions and future complications after an appendectomy has been suggested to be higher than the risk of future appendicitis and increased economic costs. For the reasons, an incidental appendectomy is currently not advocated. Next topic under the appendix is special circumstances. First case under special circumstances is the appendicitis in children. Almost 1 in 8 children undergo workup for the diagnosis of appendicitis. Of these, infants and young children are the most likely to present with perforated disease, 51% to 100%, while school-aged children have lower rates of perforation. While most age groups demonstrate the same symptoms previously described in adults, neonates can also present with abdominal distension and lethargy or irritability. The pediatric appendicitis score has components similar to the Alvarado score and is scored of 10 points with maximum weight of 2 points each. For right lower quadrant, tenderness and pain with cough, percussion or happing. A score of 7 or greater indicates the patient has high chance of having appendicitis, 78 to 96%. In pediatric population, special consideration must be made to exclude relevant differential diagnosis such as intussusception, where you can see current jelly stools and abdominal mass. For gastroenteritis, often no leukocytosis. For malrotation, there's pain out of proportion. For pregnancy, can be ectopic. For mesenteric adenitis, torsion of the omentum and ovarian testicular torsion. So let's now read the table 30-3. It is management of intraoperative findings mimicking appendicitis. First case is the ovarian torsion. How will you manage? Conservative management with detorsion and oophoropexy. Next is Crohn's terminal ileitis. Appendectomy if base is inflamed. Next is Meckel's diverticulitis, segmental small bowel resection, and primary anastomosis. Next is appendiceal mass, laparoscopic appendectomy or ileocystectomy without capsular disruption or spillage and retrieval in a bag. Okay, next page. Still under the appendicitis in children. With regard to the management of children with appendicitis, early appendicitis is treated preferably with a laparoscopic appendectomy, which has better outcomes than open appendectomies in children. For patients with complicated appendicitis, urgent appendectomy is advocated in setting of no abscess or mass. Laparoscopic appendectomy appears to retain its benefits in this setting as well. In the setting of a perforation, antibiotics are continued after surgery for at least 3 days and preferably 5 days, according to the APSA guidelines. Management of perforated appendicitis with abscess is similar to adults, although no adverse effects of an early laparoscopic appendectomy have been seen even in this setting. Non-operative management of appendicitis has also been studied in children. It may be safe for children with early presentation, those who are less than 48 hours, limited inflammation, WBC less than 18,000 cubic millimeter, appendiculitis, and no evidence of rupture on imaging. Patients are usually administered IV antibiotics until inflammation reduces, and then transitioned to oral antibiotics. This is usually effective in reducing inflammation for 88 to 92%, but a recurrence rate of 22% at 1 year, and there's increased resource utilization. So that's it for the special case in children. Okay, next is appendicitis in older adults. Older adults patients can have diminished inflammation and thus present with perforation or abscess more frequently. Such patients are at higher risk for complications because of their premorbid conditions, and it is more prudent to obtain definitive diagnostic imaging prior to taking patients to the operating room. Laparoscopic appendectomy is safe and might allow patients to reduce pain and their hospital stay. So that's it for appendicitis in older adults. Next is appendicitis in pregnancy. Appendicitis occurs in 1 in 800 to 1 in 1,000 pregnancies, mostly in the first and second trimesters. Its incidents are rare in the antepartum state, and it can occur in the postpartum state in geriatric pregnancies, maternal age greater than 35 years. While the majority of the clinical features are similar, patients can also present with heartburn, bowel irregularity, flatulence, or a change in the bowel habits. The point of maximum tenderness is usually displaced on physical exam. Ultrasonography is the preferred imaging modality, although non-visualization can occur. Sensitivity can vary from 67 to 100%, and specificity varies from 93 to 96%. An alternative imaging modality is MRI. with sensitivity of 94% and specificity of 97%. While CT can be performed in pregnancy, the risk of fetal irradiation leads many practitioners to avoid it unless other modalities are inconclusive. When discussing options with the patient and the patient's family, it is important to note that the risk of fetal loss is up to 36% if appendiceal perforation occurs. Therefore, there remains a lower threshold to operate on such patients with an acceptable negative exploration rate of as high as 30%. Laparoscopic appendectomies can be safely performed in pregnant patients. Although studies suggest a variable but reproducible higher rate of fetal loss, around 7% versus 3%, than open techniques. Lower intra-abdominal pressure, which is 10 to 12 millimeters mercury, during insufflation have been suggested to reduce early labor. Non-operative management has also been proposed for pregnant patients, but treatment failures have been recorded as high as 25%. So that's it for appendicitis in pregnancy. I will see you again in the part 5 to continue this chapter. Thank you.